Dr. Ritika will be starting on tackling regressions.
A very good morning. Can I just have... I'll be talking about regression and retreatments, when and how. I'd first be starting about the LASIK procedure and then moving on to the SMILE. The incidence of a regression and the requirement for retreatment with modern technology is lower than 3 to 5%. Early regression may happen within a year. It may be undercorrection or regression, and late regression can be seen at a later age. So I'll be discussing the pre-op examination, the timing and the methods of enhancement. What you must know is that you must have a follow-up serial workup of patients who show up with refractive error post-refractive surgery. The refraction should be stable for at least 3 months, topography stable for at least 3 months, with an optimum ocular surface and epithelial mapping, because you don't want the epithelial hyperplasia to be going on. It is also very important that sometimes you get late regression when a patient is about 45, 40. Then there is an element of lenticular myopia. So, and myopes develop earlier cataract. So even at the age of 40, do look that if there is a nuclear sclerosis coming in, don't go touch the cornea at that time. It is wise to have epithelial maps, because you know the epithelium tends to mask the effect of any irregularity. So you must know that the epithelial remodeling is stable before you're touching the cornea. And of course, there is an element of ectasia that can happen as a complication, which also manifests as a post-op refractive error, and that has a completely different line of treatment. And ectasia can happen even post-PRK and even post-SMILE, so it must be ruled out. To prevent the chances of regression, we have now normogram adjustments, better machines, and the possibility of combining extra procedures in patients with higher refractive error, though I am still on the fence about the science and the truth about the extra procedure. After a complete workup, I would just like to add that an ASOCT is sometimes very useful. It's actually all the time very useful, and the planes may be better seen in the earlier time. The later you stay, the planes may become fainter. So it is a good idea to do an anterior segment OCT in the first few weeks to know the planes in terms of the depth. The most commonly done technique for LASIK is a flap relift. You can mark the flap with a marker or a 30 gauge on the slit lamp, the flap edge, and gently lift the flap. It is quite easy to lift the flap, even multiple years after surgery. So you see drying the surface and just dimpling the edge. It is easier to lift microkeratome flaps than femto flaps. You must try to minimally disturb the epithelium, because the only great risk that you have in relifting a flap is the risk of epithelial ingrowth. So this is the flap lift that we are doing. This is a 10-year plus flap. Some studies have shown that the risk of epithelial ingrowth increases significantly after a 3-year-old flap. So then you can opt for a PRK procedure. However, there are disadvantages of PRK other than the chance of longer recovery. Haze is always higher in a retreatment. So even if you're correcting a small error, you will have to use MMC. And when you do a PRK, you've disturbed the epithelium. And epithelial remodeling starts in again, which again makes it a little unpredictable. So this procedure is what we prefer, the flap relift. You can put in a BCL if you feel that the flap is not adhering back, but I don't do that. There's some studies that say that BCL may be counterintuitive. So this is a case where we've decided to recut. So recutting is usually done at a deeper level. It's a very old case. Again, microkeratome had greater variation in the depth. So when we recut here, we plan to go deeper, but as you see, we will be lifting. Can you shut the lights? So this sliver is actually from the previous flap. So we are not really deeper here. There's been a shearing and we've actually folded on part of the stroma, which was part of the flap. So therefore, it is very important to know the planes. The planes fortunately have become more predictable with the femtosecond laser. You must have an even surface of the stroma before you laser. So this is just unfolding, and then because the surface is fairly smooth and there's really no sliver, it was just a fold, we laser and put this back. Like I said, you must use MMC in all cases of enhancement if you're doing even a small number, small power for surface ablation. And for particularly thin flaps, when you remove the epithelium, you have to take care that the flap folds are not there, and you should try and not breach the flap. You should not go deeper than the flap, because then you'll have definitely more haze. Coming on to smile, smile has lower enhancement rates. In our experience, is less than 1%. Peculiarity that you must rule out in smile is interface fluid in the early post-op period, because if you have pockets of fluid, that can manifest as shifting myopia. A high pressure and interface fluid, it can give transient myopia in the immediate post-op. That must be ruled out. And like with LASIK, you must know your planes. And like I said, look at the 1 day, 1 month and 1 year OCT. It is so much easier to look at the planes in the earlier part. Though they can be discerned fatally, the discreteness goes away. So knowing planes, these are the planes that you see in smile. This is the posterior cut of the lenticule, the anterior or the cap cut, and of course you have the side cut. Whenever we are doing retreatment in smile, it comes under some criticism that there is no option of re-smile. At present, that is true, but there are many other options available. The simplest option is surface ablation, where you simply remove the epithelium and again do a PRK kind of procedure. However, the risk of haze post PRK, post smile is much higher. So you must use MMC again and cold BSS. This is also known to reduce the risk of haze. There are people like Dr. Dan Reinstein who cut the cap at a very deep level, like 140 micron, deeper than that. So you have enough tissue to create a flap above the lenticule. The standard deviation of migration, see the air bubbles migrate to the area of least resistance. So if there is another plane available within 18 microns, they may cross cut each other. So you want to be 18 microns away from any intersecting plane. So if your flap or the top of the lenticule or the cap is at 135 or 140, the epithelium, you have enough space to create a 100 micron flap. 18 microns away from the epithelium and 18 microns away from each possible plane. So this is a thin flap LASIK that can be done. Remember, there is a side cut also there, so you have to use two instruments sometimes to lift the flap which have cuts above it. We actually create a cap at 100 microns. So if we have to do a deeper flap, it would be counterintuitive to the biomechanics. So we use the cap to flap technique of a circle scan. So you have already a plane at the cap level of 100 microns. We have to convert that to a flap. So this is a possibility that you do a side cut and that plane gets converted to a flap. But the diameter of a cap is less than that what is desired for a flap. So you create a lamellar extension. This is the junction cut, because you're not exactly sure that there may be a variation of the depth of the cap. So you give a junction cut to make sure that you meet the cap, a lamellar extension, and then a side cut to convert the cap to a flap. There were 3 patterns that were made: junction going up, junction going down, and junction going up and down. This D pattern was seen to be most effective. So just quickly going over what you see. So here you have a 7.7 cap, and if it's a small treatment, myopic treatment, so this side cut only has been chosen. This side cut only option can also be chosen when you have suction loss. This is the side cut only option. This is the D pattern I was talking about. So you just go in with this, you increase the depth beyond the depth of the cap and simply get a side cut. This is just a short video of the circle. So the 7.7 is being converted to 8.8. So the lamellar cut is causing the extension. This is the inner diameter. So you see that we are creating a junction going from 100 microns to 140. So you are creating that cut to intersect. Just ending with this. So this is how it happens. This is the junction cut, the lamellar extension, and the side cut. And the advantage of this is that unlike a flap relift, this is a fresh cut. So the chances of epithelial ingrowth are not there, which is a real risk post flap relift. Simply laser and you put this back on like a flap. And the results are fairly successful. There are studies going on ReSmile. This is just a simple pop quiz. This is something we've encountered in, actually I've had people across our locations encounter this. This is a patient we are taking up for a femto procedure of SMILE. You see the dark spots that have come in. We had to abort this procedure because there are large dark spots and it's come in even at the second cut. So what has happened here? Why has this happened? This is another case. You see when the PI is coming up, there is a lot of moisture here. This moisture has come in because the patient is masked and the PI is getting fogged. So this is a new complication. This interferes with the laser pattern and can be, and therefore you must tape the mask or unmask your patient's post-refractive surgery. Thank you for your attention.
Thanks a lot, Ritika, for covering in detail the various modalities for enhancement. If Sujata madam is ready and she can just set up her laptop, we'll take a couple of quick questions. There was a lot of initial enthusiasm surrounding extra procedures and their possible potential to reduce incidence of regression. But now, 8 to 10 years on after extra procedures, what is the general consensus and opinion from the panelists? Do you all feel it has any role in reducing regression? Doctor.
I think we at least are, I'm a fence sitter for extra because I think that I don't fully understand the role. Dr. Rohit would be able to possibly regression.
I think Sheetal published a paper where they looked at two randomized groups of ectasia as thing. I think if you look at ectasia as a fear factor, then probably yes. In a borderline thin corneas, or you feel that I don't think anybody has studied on regression.
And there was an initial talk about using it for hyperopia, particularly for regression, but we don't have enough cases and experience so as to. Yeah.
And incidence of regression, sir? Any LASIK versus SMILE? Generally, what are you seeing? Any differences? It's almost the same? Same almost. So,
If at all you're using an extra procedure, I feel it's better combined with the PRK rather than SMILE or a flap because the reach of the oxygen to the interface, when there's a cap or a flap in front, it's not so good. I think intuitively, if it's just the epithelium that's debrided and then you do extra, it might be more effective.
And we normally do extra for the borderline topographies, and I feel it's counterintuitive to again do a flap or a SMILE in a borderline topography.
Mostly combine it